Hello again. For part 2, we have lipoprotein methods. Various methods have been used for the separation and quantitation of serum lipoproteins. This includes ultracentrifugation, electrophoretic separations, chemical precipitation methods, antibodies, chromatographic methods, and direct homogeneous reagents. First, we have ultracentrifugation. The range in density observed among the lipoprotein classes is a function of the relative lipid and protein content and enables fractionation by density as mentioned in part 1. Next is electrophoretic separations. Electrophoretic separations take advantage of differences in charge and size. For chemical precipitation methods, it was once common in clinical laboratories and now primarily used in research lab. It depends on particle size, charge, and differences in apolipoprotein content. For chromatographic methods, these take advantage of size differences in molecular sieving methods or composition in affinity methods using, for example, heparin cephalose. Most common in clinical laboratories are the direct homogeneous reagents. They are designed for fully automated use with chemistry analyzers using combinations of detergents. Next, we have apolipoprotein methods. Apolipoproteins are commonly measured in research and some specialty laboratories supporting cardiovascular practices or clinical studies measure them routinely in addition to the lipoproteins. For clinical diagnostic purposes, three apolipoproteins in particular have been of interest. We have ApoB, ApoA1, and LPA. For ApoB, this is the major protein of LDL and VLDL. It is an indicator of combined LDL and VLDL concentration that can be measured directly in serum by immunoassay. Some studies suggest that ApoB may be a better indicator of atherogenic particles than LDL. Next is ApoA1. It is the major protein of HDL. It could be measured directly in serum in place of separation and analysis of HDL. Lastly would be LPA. It is the variant of LDL shown to be an independent indicator of CHD risk, and it is sometimes determined for managing these patients. LPA has a pre-beta mobility on agarose electrophoresis and can be quantified by this technique. Measurement of these three apolipoproteins considered to be emerging markers and can be useful in patient management by experienced practitioners. The apolipoproteins are commonly measured by immunoassays of various types, with several commercial kit methods available. Most common in routine laboratories are turbidimetric assays for chemistry analyzers or nephelometric assays for dedicated nephelometers. Table 10.3 listed down the adult reference ranges for lipids. Total cholesterol having 140 to 200 milligrams per deciliter, HDL of 40 to 75, LDL of 50 to 130, and triglycerides of 60 to 150. Next, we have phospholipid measurement. Quantitative measurements of phospholipids are primarily done for research but not as part of routine laboratory assessments of lipids and lipoproteins because they have not been shown to add any value for cardiovascular risk prediction. The choline-containing phospholipids lecithin, lysolecithin, and sphingomyelin, which account for at least 95% of total phospholipids in serum, can be measured by enzymatic reaction sequence using phospholipase D, choline oxidase, and horseradish peroxidase. Lastly, for lipid and lipoprotein analysis, we have fatty acid measurement. Although studies suggest that fatty acids have potential in assessing CHD risk, analysis is also primarily used in research lab for studies of diet. Less common is their measurement in the diagnosis of rare genetic conditions. Individual fatty acids can be analyzed by gas liquid chromatography, but enzymatic methods exist for measuring total plasma free fatty acids. Lastly, for specimen collection for lipoprotein measurement, serum is the sample of choice for lipoprotein measurement in the routine clinical laboratory. Ethylene diamine tetraacetic acid or EDTA plasma was the traditional choice in lipid research lab, especially for lipoprotein separations because the anticoagulant was thought to enhance stability by chelating metal ions. EDTA, however, has potential disadvantages that discourage routine use. Microclots, which can form in plasma during storage, could plug the sampling probes on the modern chemistry analyzers. EDTA also osmotically draws water from the red cells, diluting the plasma constituents, and the dilution effect can vary. Thank you for listening. For our reference, we have Clinical Chemistry Principles, Techniques, and Correlations by Bishop, 9th edition, Chapter 10.